Okay, I'm absolutely not going to sit down now for this very brief introduction, but I'd like to say to everybody, thank you so much for coming today to, I suppose, Ireland's very first, and hopefully not the only, EDS conference. So thank you all for being involved in that. Just a brief explanation of today, really, I suppose. First of all, in case you haven't guessed, we have the most wonderful, fabulous Dr. Brian Mulcahy here on my left.
Brian Mulcahy.
So he's going to speak to us first of all. Then we're going to have a talk by Linda. Sorry, this mic is kind of coming and going. Sorry for that. Linda from Arthritis Ireland, who is going to speak to us on basically living with chronic pain and hopefully give us some nice tips and things on that. We are going to take a break as well for tea and coffee and biscuits as well at that stage. And then last but absolutely not least, we have Dr. Jane Simmons from the UK, who's actually going to Skype call us at about 4 o'clock or thereabouts as well too. So we should probably get out of here at about 5 o'clock. If anybody is kind of getting pains and things from sitting down and, you know, staying in the same position, by all means throw yourself in the ground. That's why we've carpet in the room. We specifically requested it. But by all means get up, move around, and we will take maybe movement breaks every now and then as well too, okay? So I'll pass you over now to Brian Mulcahy, and thank you all again.
Thanks, Deirdre. Do you want me to put on a mic? Oh, you're here? Hello?
Yeah.
Oh. Two things, folks. Number one, thank you for asking me to come along today. I've had a particular interest in hypermobility since I worked in London in 1997. I was working in a place called Chase Farm Hospital, which is in Middlesex, which is up just south of the M25. And we used to have a clinical meeting session every week there. And one of the weeks, Professor Rodney Graham was invited to talk. And he gave an excellent talk that day on hypermobility syndrome, which I'd never, ever, ever heard of before. I still actually have the notes from the talk that day. And since then, and since I came back to Ireland in 1999, I've been interested in picking up people with hypermobility. And it came to my attention, and still comes to my attention, that in a lot of cases, people are just overlooked. And I met him again in Belfast about 2 months ago. He was in the Irish Society of Rheumatology and he gave an updated talk. And again, it was a fascinating, fantastic talk. So this is where I come from, why I am here to talk about Ehlers-Danlos today, apart from being invited by Deirdre. And the second thing is, if anybody finds out the result of the score in their rugby, please don't tell me I'm taping it, okay? All right. I was wondering what symbol I was going to use for Ehlers-Danlos. I was thinking about the dove as a symbol of hope. But then I did a bit of research, and we said, well, maybe we could use the zebra. I don't know where that comes from, but it looks good anyway, doesn't it? But then I said, well, if it's going to be the Ireland one, well, maybe we should have, next slide please, Tim.
I'll get this right in a second.
Maybe we should have this. Maybe this should be our symbol of Ehlers-Danlos Awareness Association of Ireland from now on. Next slide please, Tim. Anybody know who this is?
There's two people, isn't it, that founded it?
Yeah, that's right. This is Eric Ehlers. Okay, Danish, dermatologist. Next slide, please. And who's this? Alexander Danlos. He was French, and I think it was about 1908 the two of them got together. And the term Ehlers-Danlos was next slide, please. We all know who this is, don't we? Most of us have met Professor Graham. A very, very, very nice, unassuming, brilliant man, and he's done superb research in hypermobility and Ehlers-Danlos. Next slide, please. Now, what I'm going to do today, and I want this talk to be interactive, okay? If you have any questions, just stop me, okay? And Lauren, if you want to walk around or go away or whatever, as we've agreed, you could do so, okay? I'm going to talk about what is it, how you recognize it, how you diagnose it, and how you treat Ehlers-Danlos, hypermobility syndrome. Next slide, please. Now, if we're going to talk about Ehlers-Danlos syndrome, we have to talk about hypermobile joints, we have to talk about joint hypermobility syndrome, and we had a discussion about this just outside, and then we'll talk about Ehlers-Danlos syndrome. Next slide, please. Okay, so what is it? It's a dysfunction or disorder of collagen. Next slide, please. Not the type that we put in here, okay? And it's an inherited condition, so it's a disorder of DNA. Next slide, please. Okay, so there are a few of these hereditary disorders of connective tissue. Ehlers-Danlos, Marfan syndrome, I don't know if you've heard of Marfan's, or osteogenesis imperfecta, and you can have overlaps amongst them. And the inheritance can be dominant, which means that if your parent has it, you will inherit it. Recessive means you have to get it from both parents. And X-linked means that only men can get it. Now, these are some of the genes that are involved. Please don't ask me about them again, because I'm not a scientist, I'm a clinician. Okay, I'm sure you know more about them anyway than I do. Next slide, please. Okay, so what is this? What are we looking at here? Collagen, yeah. And what's so important about collagen? Next slide. Strength. Okay, stability. This is what we're talking about. Next slide, please. Interesting? Okay. All right. It says a lot, doesn't it? I don't have to say any more, apart from what this says. Without collagen, you turn into a big puddle. So if you've got an abnormality in collagen that makes you flexible, you're not going to have as much stability. Next slide, please. Okay. So what's this? This is a spectrum. Okay, so you've got a spectrum of flexibility. You'll see that in the population anyway. People who are stiff. I mean, I have patients who are hypomobile. When you try to raise their leg off the bed, you just can't do it because they're collagen stiff. Next slide, please. So you have the Terminator, who's going to be very, very stiff. Next slide. And the Thing, who's stiff out as well. And then we have Captain Fantastic. So you have that spectrum of flexibility in the population. Okay? Next slide, please. Okay, so I'm going to talk about hypermobility. What defines hypermobility? It's said that approximately 10 to 30% of the people, of the population, have got hypermobile joints. That's 10 to 30, depending on what book you read. Okay, so 10 to 30%. Who's this? Anybody? Hippocrates. He was the first to talk about it. He noticed in a particular group of Syrians, I think, who were unable to throw a javelin or pull a string on a bow. They were so hypermobile. That's going back to 4 BC. Next slide, please. Okay, so we know this, right? How do you define hypermobility? Well, if you can oppose your thumb against ipsilateral forearm, so like this, that's one of the signs that you look for. Okay, so that's one. Next slide. And again, if you can put your finger greater than 90 degrees, one of your fingers, that's another sign that we use. Now remember, you can be hypermobile everywhere, but these are just the signs that we use to enable us to make a diagnosis of hypermobility. Next slide, please. And this is the elbow, okay? So if you can hyperextend your elbow but beyond 10 degrees, now I can't do it, but if you can do it beyond 10 degrees, that in itself is a definite sign. Next slide. Another sign. The same at the knee. If you could hyperextend your knee beyond 10 degrees, it is a sign of hypermobility at that particular joint. Now remember, you can have it at many joints, or you can have it at one joint. Next slide, please. I can't do this. I bet you a lot of you can do it. And that's another clinical sign. So, who made up all these signs? Baton. Next slide, please. Who's this? Dr. Baton. So that's the Baton score that we use. So, 2, okay, 4, 6, 8, and 9. So there are the 9 signs that we use. And it said if you have over 4 out of 9, then that you are classed as being hypermobile. Now, again, I was talking to Rodney Graham about this, and he was saying, look, you can just one joint, and you can be hypermobile. But this is what we use. And this is a classification. It was used to classify patients, particularly for scientific studies, not necessarily to be used specifically initially as a clinical diagnosis. Next slide, please. So, the benefits of being hypermobile. Dancers. Next slide. Gymnasts. Ballet dancers. Pianists. Now, and of course, party pieces. We all had our party pieces before, didn't we? Oh, can you put your foot into your mouth, please? Next slide, please. Okay, and now we come to the joint hypermobility syndrome. So you're going one step beyond, because you have people who are hypermobile who don't have symptoms. They're just hypermobile. But then you have people with the joint hypermobility syndrome. Next slide, please. Okay, there's a prize. Where is this? Does anybody recognize that building?
Right.
Yeah, it is Brighton. It's the Grand Hotel in Brighton. What happened there in is it 84? Exactly. Okay. So what have we got from this? Why did I put the slide up here? Next slide. The Brighton criteria for diagnosing joint hypermobility syndrome. Now, it is very busy slide. I apologise for that, but I think it's important that we kind of go through it. Okay. So here's our Baton score of 4, and arthralgia. Arthralgia means pain in the joint. Okay. So arthralgia for no particular reason. In other words, your joints are sore. You haven't injured them, but they're talking to you. So what's wrong with me? Okay, now, so it's a 2 major, or 1 major and 2 minor. Okay? So this is for the joint hypermobility syndrome. Now, the one little issue I have with this, right? So if we go down through it, a Baton score of 1, 2, or 3, obviously that excludes this, okay? Arthralgia, or back pain, which is another thing. And we have dislocation or subluxation. Who said that they didn't have Ehlers-Danlos because they didn't dislocate? Isn't that amazing, isn't it? Look at that. Look. That's part of the criteria. Soft tissue rheumatism, what does that mean? Rheumatism is just an umbrella term, okay? It means an ache or pain anywhere from any muscle, joint. That's what rheumatism is. Nothing more than that. Epicondylitis is a tennis elbow. Okay, tenosynovitis is that you can get inflammation along your tendon. Marfanoid status. Now, the marfanoid status means very tall, very thin, and with a very wide span, and your span is greater than your actual height. Okay. Now, look at this. This is, I find, very, very, very interesting. Right? It brings in abnormal skin tissue. But they say the joint hypermobility 3 is Ehlers-Danlos without the skin. So I think that shouldn't be in there at all. But I mean, and then there are other ones that we look for. So 2 major, all right. So you have the hypermobility syndrome, but you have symptoms as well. Okay. Next slide, please. Now, you might say, "What in God's name is this?" Does anybody recognise that paint? It's called the Three Graces. Okay. It's from a 15th century Dutch painter. Now, does anybody recognize, does anybody see anything there? Well, these are sisters. You can see the scoliosis, right? You can see the flat feet, okay, and hypermobility at the metacarpophalangeal joints. That's in the 15th century. Next slide, please. And now we come to Ehlers-Danlos. So we have hypermobility, we have hypermobility syndrome, and now we have Ehlers-Danlos. Next slide, please. And how do we make a diagnosis? How do we come to the diagnosis? Because it's important to make a diagnosis. If you don't make a diagnosis, how do you know what you're dealing with? Next slide, please. Now, when medics try to make a diagnosis, there's 3 things we do. History, examination, and blood tests. But the most important thing is the history. So we take a history. Next slide, please. And generally, the examination confirms our clinical diagnosis that we've got from the history itself, generally speaking. So the history is, you have to listen to people. If you don't listen to them, you're going to miss the diagnosis. And then, of course, you get blood tests. Is there any blood tests in Ehlers-Danlos? Okay, next slide, please. Anyone know where this is?
Somewhere tempted.
It is. I've been here, and you say, "What in God's name is he showing this?" You recognise the Brighton, but do you recognise? I'll give you a hint. Have anybody ever been on a Mediterranean cruise, and you stopped off in Nice? No. Well, they stop off in Villefranche. And you say, "What's Villefranche got to do?" It's the Villefranche classification of Ehlers-Danlos. There's a new classification. Now, what you do here, if anybody ever goes, the Up around here in the sea, that's where the boats dock. Okay, you get into a nice tender. You get down in here, you cross over here, and you get the train to Nice. Well worth it. Fantastic. It's a beautiful spot, Villefranche. Next slide, please. Because it's the Villefranche classification. They met in 1997. People who are interested, medics, scientists who are interested in Ehlers-Danlos, because we have this classification, the old one here, 1 to 11. I always get mixed up with them. I say, oh my God, is that 2, 3, 5, 7? What is it? So they're divided into classic, hypermobility, vascular, which is the dodgy type, really. That's the real dodgy type, and that's quite rare. These are the two classic ones, 1 and 2. Hypermobility we've talked about. Does it exist? Well, you know, I'm not sure about that. I think it's just all overlap. And does it matter? I don't think so. So we'll just move away from that swiftly. Next slide, please. Okay. This is an important, I think you should think about this because it's an overlap between joints, skin, and others, then, other parts of the body. And different people will have different percentages, really. Okay? So there'll be different percentages. Some will be extremely hypermobile, others will have awful skin involvement, others will have vascular involvement, others will have autonomic involvement, others will have abdominal involvement. So the people will differ. There isn't just one type. Okay, I think again, within Ehlers-Danlos, I think there's a spectrum. Okay, from one side of it to the other side. Next slide, please. Now, the interesting thing about Ehlers-Danlos is that you're born with it. Okay, but how many people are diagnosed at this age? Very few. Generally speaking, next slide, it's in teenagers. But I mean, it's obvious with babies anyway, they've got flexible skin, they've got flexible joints and stuff, and they can't tell you, oh, I'm in pain. And we have one of our members who's quite young, who's 7, who's suffering quite a lot. But generally speaking, it's around a teenage year.
Could I just ask you,
Yeah.
with regards to the age of diagnosis and the age of the onset of symptoms, is it in any way an indication of the way it's going to go? As in, for example, if you're very young when you get the diagnosis, when you start showing symptoms, does that mean that you've got a higher possibility of it getting worse and worse and worse as you age, or will it slow down, if you know what I mean?
I think you just can't answer that. Possibly both. It's a question I'm asked a lot by patients with rheumatoid. What's going to happen? And you see that what the problem is, there are no indicators of severity apart from the clinical. I think the way to address that would be to examine the patient at the time and see the type and the extent of the involvement. Because in rheumatoid, which is another chronic illness, we have markers of severity, so we can do a blood test and we can say, well, you know, you've got this, ergo you're going to have very aggressive disease. We don't have that in Ehlers-Danlos as yet. When they're going to have it. So I think it's just you examine the patients and see, you know, the degree of hypermobility, degree of skin involvement. Thereafter, I mean, is there going to be abdominal involvement? Is there going to be cardiac involvement? We won't know that initially with the child because they're too young. So I think the answer to that is just the examination, the clinical examination. Unfortunately, we don't have any markers. What's important about this? This is a clinical sign. Pretty girl.
Pale skin.
Perfect. Well done. Pale skin. It is a sign of people with Ehlers-Danlos, despite the fact that Ehlers-Danlos is quite common all around the world. Okay? All around the world, and both in male and female. Pale skin. Next slide, please. And of course, we'll go through the various different clinical signs that we'd look for. So bruising, easy bruising. Next slide. So what do we see here? Scarring. And these little growths here. Molluscoid pseudotumors is the medical term for them. Next slide, please. And what have we got here? We've got a scar, hypertrophic scar with an injury. Okay. So this is what we're looking for. It's important to look for this. So you've got to really undress the patient and look everywhere as much as you can. Next slide, please. There are a lot of injuries there, isn't there? Mm. Next slide. Abdominal stria. It's Not easy to get a picture of striae on the web, you know, but you can download it. Next slide, please. And again, we can see the hyperextensive skin. And again, we have the injury here, we have the scarring here. Okay? And the degree of hyperextensibility will vary from patient to patient. Next slide, please. I'm sure we've seen the party. Have we seen these before, haven't we? He probably makes a living out of this.
Yeah.
Next slide, please. Okay. So remember what I said initially, that you can have hypermobility in any joint, not just the thumbs or the metacarpophalangeal joint or the elbows. So you can have it in these are what we call the distal interphalangeal joints here. So this hypermobility, it can be anywhere. So you've got to look for that. Again, next slide, please. So we look for our Brighton criteria, our Bacon criteria. So this is 1, 2, 3, 4, 5, 6, 7, 8, 9. And what's the interesting thing about this patient? Exactly. Well done, yeah. Very well done. It's amazing, actually, you know. When I examine people who don't have hypermobility syndrome, right, but are flexible, and I say, God, you're very flexible, everybody smiles. And this isn't that great. Well, why is that? Any ideas? I think it's got something got to do with yoga or something, because it's cool, you know? Oh yeah, isn't it great? Everybody smiles. God, you're very flexible. Next slide, please. And we have a classic case of pes planus, which means flat feet. Okay, next slide. And this is called Gorlin sign. Most of us can't do that. I can't do it. It's just another clinical sign. Looking for. So what are we looking for here? We're looking for hypermobility on top of the skin changes. Okay, so that's what we're looking for. So this goes beyond the hypermobility syndrome now. We're looking to see, does this person have Ehlers-Danlos syndrome? Next slide, please. And what have you got here? Dislocated shoulder. Next slide. That looks sore, doesn't it? And I have a worse one coming up, actually. That one looks very, very, very sore. Next slide, please. Look at that. Look at the kneecap is. Look at it. So easy dislocation. Now, subluxation means that the two bones are still they're still connected to a degree, whereas a dislocation is that there's no connection between the two bones. Okay, so that's the difference between a subluxation and a dislocation. This is a completely dislocated patella. Next slide, please. So what have we got here? Yeah. What you can see is you can see the ankle and the foot as well as swollen. So there's a suggestion of swelling here. You can see the ankle is swollen, and that's the blood that kind of that drains down from gravity. So what's happened? Tennis or football, they've fallen over and they've sprained their lateral ligament. But the patient with Ehlers-Danlos, that can occur very easily. So you get dislocations, you get subluxations, and you get soft tissue injury. And the problem, what's the problem with these injuries then? Number one, and I'll talk about this again, there's a heightened awareness of pain in patients with Ehlers-Danlos. I remember working with a girl called Jane Griffin. She was a consultant. She was my senior when I was working initially as a consultant in London. And I remember her saying, because she had an interest in hypermobility as well, because she got Rodney Graham over to speak for us, as I said. I remember her saying that she had a patient with hypermobility syndrome. And the only way she could control her pain was to bring her in and give her IV morphine. And I thought, what? But there's a heightened awareness of pain. So if I injure myself, I'm going to be sore. But if a person with Ehlers-Danlos injures themselves, they're going to be sore to the power of 10. And not only do they have a heightened awareness of pain, what happens? It takes a lot longer for the injuries to heal. A lot longer for them to heal. Next slide, please. Next slide, please. I don't know what happened there. Maybe I was drinking too many bummers. What have we got here? This is very important. This is a very important slide, because this can actually, this leads to a lot of misdiagnosis. What we have here is we have a swollen joint. Okay? So So this is what we call, these are the metacarpophalangeal joints, your knuckles. These are the interphalangeal, and that's the distal, that's the proximal interphalangeal, and that's the distal interphalangeal. See, this is swollen here, but you can get spontaneous swelling, no injury. The joint can swell up. Go down to your doctor. What does your doctor diagnose you as having?
Arthritis.
Exactly. Precisely. Without looking for hypermobility, without looking for a history of subluxations, dislocations, easy injuries, without looking for changes in the skin. Next slide.
Just on that note, if you're getting that, is it not a lead up to arthritis if you're constantly subluxing or dislocating?
Well, excuse me folks, osteoarthritis, yes. There is premature degenerative change. Yeah, there's no question about that. You will get, I mean, if I dislocate my ankle, and I keep on dislocating my ankle, I'll eventually get osteoarthritis in the ankle. But not inflammatory arthritis. Degenerative arthritis, but not inflammatory. There's a big difference between the two, because the treatments are completely different. Whereas there are treatments for rheumatoid, there are not treatments for osteo. And the treatments for rheumatoid have come on hugely in the past 3 decades. I mean, it is nearly, well, it's a controllable disease, whereas before it was nearly an incurable disease. Next slide, please. Okay, what have we got here? Exactly. Precisely. Next slide here, please. And what have we got here? Kyphosis. So we look for kyphoscoliosis. Going back to the Three Graces, the painting with the kyphoscoliosis. Next slide, please. Now, I give you a prize. I don't have it, but I give it to you if I had it. If you tell me what this is. That's very unfair. This is, excuse me? Bone? Yeah. Excellent. Excellent. This is a picture of an osteoporotic vertebra. So you can see it looks very fragile, doesn't it? Okay. So what happens with fragility? Next slide, please. These are 3 sisters with Ehlers-Danlos. Okay. Breaks, breaks, breaks. So fracturing easily. Next slide, please. Okay. So what's the person going to tell you if you ask them? All right, I have bruising, I have dislocated, I have sublux. What are they going to talk to you really about? That really bothers them most is pain. Okay, because it can dominate their life. Pain can dominate a person with Ehlers-Danlos because they can get spontaneous pain. Next slide, please. And it can predominate. The pain can be absolutely intense. And again, I go back to the case of that patient in London that my colleague had to bring in, and the only way she could control her pain is with IV opiates. Next slide, please. And the pain can be anywhere. Okay, so complaining of back pain. Next slide, please. Neck pain. Next slide, please. You can have pain all over. Next slide, please. Okay, what's this? Well done. Excellent. Now, I'm just going to digress just a little bit about fibromyalgia. Fibromyalgia is another chronic pain syndrome. Okay? It's a pain syndrome in itself. Generally, the people aren't, they have no hypermobility. Okay, there's no skin involvement, they don't have Ehlers-Danlos. So, people with fibromyalgia don't always have Ehlers-Danlos. A lot of people with Ehlers-Danlos can have fibromyalgia. A lot of people with fibromyalgia have underlying stress or depression, or they've had trauma, be it physical or psychological trauma, that can drive this. And what they have is they have constant pain in a widespread distribution. Okay, and what you do is you look for, these are what they call tender trigger spots. Okay, so you look for these signs on examination. Now, I have lots, this is another particular condition that I have a particular interest in, because I have lots of patients with fibromyalgia. And it's a very contentious issue in medical circles, because a lot of doctors believe it doesn't exist. They believe that everybody with fibromyalgia is nuts, essentially. That's what they say. And they're completely dismissed. And the interesting thing I say, and the way I come back at that, is that I have hundreds of people with fibromyalgia patients, okay, that are not related, that have never spoken to each other, that haven't gone and read medical literature, and they all come in, and when I examine, this is what I find. So, they can't all be nuts. So anyways, that's why respond to my colleagues. But what these people complain of is pain, and they have constant pain. And they've got pain with fatigue and sleep disturbance. And that can happen in patients with Ehlers-Danlos as well. Next slide, please.
Sorry, can I, going on to it again.
Yeah, yeah.
How can you differentiate then, even if you have some of us have Ehlers-Danlos and have been diagnosed with fibromyalgia? Is it because of the certain trigger points with fibromyalgia only?
Yes, is probably an answer to that. Generally speaking, with fibromyalgia, it's widespread pain with severe fatigue and sleep disturbance. So you can have a person come in with Ehlers-Danlos, and they've got the hypermobility, right? They've got the skin changes, so you'll know that, okay, this is what it is, Ehlers-Danlos, and they're not saying, oh, look, I've got a pain in my hand, and I didn't injure my hand, or I've got a pain in my back. They'll say, I'm sore all over. Now, those of us here who have Ehlers-Danlos, are we all sore all over today? No. Whereas with fibromyalgia, they've got sores
so
all
it's
over.
like the pain feels like on the skin more than in joints
In the muscle,
and stuff.
it's
Yeah.
in the muscle.
Oh, okay.
Yeah. You get muscular pain in Ehlers-Danlos.
Yeah.
But it's the particular combination of the widespread pain with fatigue and then the marked sleep disturbance. Okay, so that's how you differentiate. So people with fibromyalgia suffer a huge deal. Again, coming back to pain in patients with Ehlers-Danlos, headaches, quite common. Next slide, please. So what does it lead to? Despair. What in God's name am I going to do? Next slide, please. I came across this, which I found very interesting, because it leads on to another set of symptoms then. Next slide, please. Fatigue, the Mayor of London. Okay. Sleeplessness. Next slide, please. Blood pressure problems. Postural orthostatic tachycardia syndrome. Next slide, please. Tiredness. Feeling faint. Next slide, please. Why did I put this up?
It's a good exercise.
Not necessarily. I'm getting there though.
It helps.
If you go into a hot swimming pool, feel faint. Yeah? Have we come across? Yeah? Yeah? Don't like it? Because I said to people, going to go into a swimming pool, going to go water walking, I feel faint with the heat. Next slide, please. And what's this? Yeah, this is the normal, what we call sinus rhythm. So when you feel your pulse, you feel the regular rhythm. Okay, this is an ectopic beat. So you're going along and suddenly, ooh, what was that? You get a flutter. That's an ectopic beat. So people can say, oh, my heart is beating fast. Next slide, please. And what's this? This is what we call a supraventricular tachycardia. This is going at a rate of 150 beats per minute. Okay, so that's, you can actually, what you do is you get the distance between the two, right, which is, it's nearly 2 boxes there. See, 1 box, 2 boxes, and then you divide that into 300. And that's where you get the rate 150. So people get tachycardia. What happens when they get tachycardia? Next slide, please. Faint. History of faint. Okay. So you're getting the picture now. Okay. We have hypermobility. We have skin changes. We have pain. We have autonomic dysfunction. Next slide, please. Abdominal pain. Because of dysfunction of the bowel. Okay. Next slide, please. Vomiting. Next slide. Oh, why did I put this?
Diarrhea and constipation.
Exactly. A bit of both. So you could be on it a lot, doing a lot, or on it a lot, doing nothing. For days. Next slide, please. Okay, so your mind is in turmoil. Your body is in turmoil. What in God's name is going on? What are you looking for? Next slide. That's what you're looking for. So where do you go? Next slide, please. You're looking for it? At the end of the tunnel. But that's all we want. We just want, next slide, normality. Nice, smooth existence, get on, play. You know, that's what we're looking for. Next slide. Now, I call this the D-cop roundabout. Right? I said, what in God's name is he talking about? D is for doctor, C is for chiropractor, O is for, and P is for physiotherapist. Okay? Now I said, what is he talking about? I'll tell you. Next slide, please. Next slide, please. So, first protocol generally tends to be, you go to your GP, be it male or female. Next slide, please. Okay. I rest my case. Have you ever heard this?
Yeah.
Well, in fairness to people, if they say that, at least to put their hands up. But have you ever heard these?
Yeah.
A lot, I'm sure. Okay? So what happens then? You keep on coming back again and again. What happens then? Next slide. They don't want to hear about you. Right? They're suddenly beginning to turn. Oh, they're back again. And I've got 69 people outside the room, and you know, and I'm stressed, and there's a rugby match, and I watch, and I want to finish it, and I've got a game of golf to play. Next slide. And then you get the picture. Next slide. I'm talking to the converted here, aren't I? Because we've all been here before, haven't we? We've all heard this before. Next slide, please. And then you just go on and on about you and on. Like, fine, go away. What I'll do is I'll pass you on to my colleague. Next slide. So what you do then? We go to another healthcare professional. A lot of people go to physios, osteopaths, chiropractors. Next slide. Okay. Your pelvis is out or tilted. How the hell can your pelvis be out? Unless you've been involved in a root crash. How can it be out? They've got a particular speak that I don't understand. One leg is longer than the other. Have you heard that? If you measure, I've seen many people come to me. I have a longer leg. You see what you do is you measure between the anterior superior leg spine and the inside of the median malleolus. You get up your tape measure. Say you don't. It's actually the same. Right? It's not your back. It's your neck. It's not your neck. It's your feet. This is one of the biggest scams at the moment. Right? And it doesn't just happen to people with Ehlers-Danlos or hypermobility. It happens to a lot of people. You go in a back pain. Oh, you need 6 months of physio. And at the end of the 6 months, you're still in pain and say, it's your feet. You need orthotics. And how much do the orthotics cost? About €300 or €400.
Yeah.
And where do most orthotics end up? In the bin. Don't believe what your doctors say. Well, in a lot of cases it could be right, but in a lot of cases they're wrong. You need laser therapy. I said, that's a scam. Well, you have to go to up to Dublin. 6 or 7 sessions of laser. I'll send you to my osteopath clinic. Now, I have nothing against physical therapists. Absolutely nothing. I use them all the time. Okay? But you have to, they must treat you properly. In a lot of cases, they mistreat you. And I can say exactly the same about the doctors. I'm on nobody's side here, bar the patients. Full stop. And acupuncture. Okay, so you have to do 900 sessions of acupuncture. Will it cure you? No, but it'll cure you of one thing. Your bank balance will go way down. Next slide, please. So, and it's not just in Ehlers-Danlos. There are lots of other conditions that are misdiagnosed. One of them in particular in young men is a condition that I deal with a lot, is ankylosing spondylitis. Young men coming on with inflammatory back pain, and they're misdiagnosed for years. One guy came into me recently, this is just an aside, but it just illustrates, it goes on. He was in Turkey recently. He had every he had every investigation under the sun done, and they couldn't tell him what was wrong with him. Brought him home, listened to him. He came home, he's a Turkish hairdresser, listened to him, and it was quite clear for me that he had ankylosing spondylitis. So this occurs quite a lot. Next slide, please. Nearly finished now. So, we get on peed off. Next slide, please. Anyone recognize this? The Cure. Robert Smith, lead singer of The Cure. Next slide, please. The problem is there isn't a cure. And it's the case with a lot of chronic disease. Rheumatoid, ankylosing spondylitis, SLE, scleroderma, celiac, colitis, diabetes. There's no cure, unfortunately. So, what is there? Next slide, please. This is a symbol for treatment. Next slide, please. You've got to approach a patient with Ehlers-Danlos from a holistic point of view. You have to treat the mind and you have to treat the body. Because if you don't, you're going to miss it. You're just not going to treat the patient properly. Next slide, please. So it has to be a multifaceted approach, if at all possible. The problem in this country is there isn't one. There is in the UK, or in London, I should say, but there isn't in this country. Not yet anyway. And it's not just the individual. Next slide. It's the family. It's not just the family. Next slide. It's our friends, so they understand what's going on. And it's not just our friends and our family, we must get our schools involved as well, so they understand the potential problems the patients can have. Next slide, please. Why did I put this up there? Nearly finished. This, nearly. You must adopt a positive outlook. Because if you don't, any treatment that you get will not be as good. Next slide, please. Now, it's very easy for me to say this, right? But I see it. I deal with people with chronic disease all the time. That's my job. That's what I do. Predominantly rheumatoid. And I see that if the cup is half empty, the treatment's a lot more difficult. So you have to have a positive attitude. Next slide, please. I can do it. Next slide, please. You might say, oh, fuck you. That's easy for you to say, right? And there will always be times like this. So that's where treatments come in. Next slide, please. And there are medications for treating pain. Okay, so we have painkillers, anti-inflammatories. There are the likes of Lyrica, pregabalin, that type of stuff, which alter your perception of pain. And we can use anti-inflammatories, etc. when you've got dislocations and subluxations. So they all work. So you've got acute treatment, say analgesia, anti-inflammatory, and then you've long-term treatment for pain, the likes of Lyrica, etc., where, as I said, they alter your perception of pain. Next slide. Exercise. Very important. Right? And the type of exercise, generally speaking, doesn't matter. Doesn't tend to matter. But you have to balance things. Next slide, please. You don't want to over-exercise, because what happens with over-exercise? You get pain. Next slide, please. And we have to avoid certain forms of exercise. I mean, the last thing you want to do is play contact sports. Next slide, please. Particularly something like this. Imagine going into the scrum without your stimulus. Next slide, please. We all want to be Djokovic, but can you imagine that in a hypermobile ankle? What was going to happen? Gone. So you have to be careful with the type of exercise. Next slide, please. So as I said, it's a kind of a balancing act, really. Next slide, please. Physiotherapy is important, but we need physiotherapists who understand what Organised is about. Next slide, please. So that when you go to your physiotherapist, you can trust them. So there won't be 6 months of 2 sessions a week of €50 each. And next slide, please. You're not getting inappropriate therapy, like deep massage. You go in for deep massage, and what happens? You're bruised, and you're in pain for months afterwards. Next slide, please. Occupational therapy is very important as well. So your occupational therapist will look at you, will look at your disability, and will be able to help you to deal with this disability at home, at work, and outside of work as well. Next slide, please. And occasionally, psychiatry is very important, because people do get genuinely depressed. And you may need antidepressant medication, particularly if there's a fibromyalgia element as well. Next slide, please. Always, in any disease process, give up smoking. Because the treatment, generally speaking, is much more difficult in patients who smoke, and they tend to be resistant to treatment. Again, going back to a paradigm of rheumatoid, generally speaking, we don't see joint deformity in patients with rheumatoid anymore. The one group that we do see them is rheumatoid patients who smoke. So give up smoking. Next slide, please. And coming to the end now, it's important that we spread the message of Organised. So, by any means, next slide, please, that we have, so that, next slide, please, there's an awareness out there, particularly amongst the medical profession, which there isn't at the moment. Next slide, please. So that the next time you go to your primary care physician, next slide, please, they'll be looking for it. So that the next time and the time after you go back to your physician, you can say, I've got somebody now who I can trust. The person that knows the diagnosis, knows what it means, and knows how to treat it. Next slide, please. Thank you very much.
Does anyone have any questions for Dr. Mulcahy before we move on?
Could I just ask, did you say that both friends have to have this for the person?
It can be various different forms of inheritance. So it can be what we call autosomal dominant,
which means you can pick it up from one parent. It can be autosomal recessive, which means you can pick it up. You must be getting it from both parents. The genes must come down from both parents. If you get it from one parent, it means you won't get it. Or it can be X-linked, which means it can only occur in men. So there are various different forms of inheritance.
Can a parent have it without realising it and pass it on, without suffering?
Well, you can have hypermobility.
And be unaware.
And be unaware. Then you don't have the hypermobility syndrome.
Yeah.
So what you could do is you could pass on hypermobility, but your spouse could have a gene or a gene, and the two of them together then functioning together could cause hypermobility syndrome, which I think is just ADS. I mean, you saw that yourself.
My mother at 97 can put her hands flat on the ground without bending her knees. And she's extraordinarily healthy other than that.
Yeah. So she's got hypermobility. So she's too flexible.
Yeah.
So she doesn't have any of the rest of it. So, you know, she must have been great at ballet or dancing, or she'd have been a brilliant gymnast.
Just for the railing kids.
Dr. Mulcahy, just want to ask, is there any point as an adult seeking a diagnosis? You know, I've had multiple recurrent dislocations and multiple joints and all that, but is there any point, because I just find, you know, if you go into on your numerous trips to A&E with dislocations, they're kind of like, off you go again.
Yeah.
There's no follow-up, and
Yeah.
I've had many physiotherapy sessions that actually end up hurting you.
Oh yeah.
Rather, you know, you're
Well, I
in
think you should
agony
go in.
sitting
You should
there.
go in and say, "This is what I have."
Yeah.
It is very important to have the diagnosis, because people who are unaware, because it's missed all the time. I'm just amazed. Even well before I got interested in ADS, I was interested in hypermobility, and I used to look for it. And the first thing I do when I see a patient, I'd sit them down. First thing I do is I start examining their fingers. They came up with back pain. I start examining their fingers. I said, "What are you doing that for?" Honestly, is he mad or what?
So it'd be worth going
it is
for.
absolute. It is essential for your own mind.
Yeah.
Right? So that you'll go in and you say, "This is what I have." So you'll have a card and say, "Look, that's what I have."
But you can't get the diagnosis really
But it's a clinical diagnosis.
from yourself.
Yeah, it's a clinical diagnosis. But it should be from the medical profession. I mean, I just have an interest in it. But it's a clinical diagnosis. It's very, very important
There
to
are
have.
very few. Like, where do you go to get this diagnosis? Like,
Well, a lot of
we
people have been
tell
going to London, understand?
Yeah.
You know, a lot of people have been going to London to Rodney.
Well, I think what London does is put the picture together.
Yes.
Because you have a set of what appear to be isolated, unusual symptoms,
Yes.
and then suddenly they get put together.
Absolutely.
And I think that's the important.
That's the
bit of
important.
London.
And you must remember, right, that this is not unique to Ehlers-Danlos. This goes on all the time. Okay? I used the other example there of ankylosing spondylitis. It's extremely common for that to occur, even these days.
And it does make a huge difference when you're going for treatments. If you used to go to the A&E, I mean, you're treated completely different.
It's essential to have a diagnosis for many reasons, but the most important thing is at least you know yourself what's going on. Oh, and apart from being called mad, you are mad by yourself, and if you go, this can be suffering for decades.
And you have to be referred by a GP to go then to.
Well, you see, the most important thing, that's the question I'm asked all the time, right? It's always important to embrace your primary care physician, because you'll be going to him or her for antibiotics, for whatever, you know, or for other treatments. So they really must know what's going on. It's one thing that you have the diagnosis yourself, but your GP should know the diagnosis as well. So I think yes is the answer. You don't have to be referred to a specialist. I mean, you can ring up Rodney Graham's unit tomorrow and say, "Look, I want to be seen." And I say, "Fine, we'll give you it." But it's really important, you know, because we want, what we were saying is we want to spread the message. That's what you want to do. So everybody is aware. That's going to be difficult, if not impossible. But if we could at least push it out a little bit. I mean, I'm going to give this talk to GPs in January. Yeah, I'm going to give this talk to GPs in January. I'm going to get one of the drug companies to sponsor the talks. Get them all. You have to get the drug companies to sponsor it because the GPs won't come otherwise, right? Yeah. And I'm going to give this exact same talk in January, so that we start spreading the message.
Can I ask you, just at that, would you have any interest in having one or two of the people here who suffer from it?
Yeah.
Give them a talk. From a patient point of view.
Initially, that mightn't be the right thing to do. And you might say, why not? Because it'll be an evening session, right? They'll have all had a day full of seeing patients, and the last thing they'll want to do is see more. You might say, sorry, that's a couple, but I know what goes on in their minds, you know? And they'll be knackered. And the last thing they want is another patient. What the best thing, that tends to really work in the academic setting. For instance, when we're giving this talk in a hospital-based setting, at a lunchtime meeting with other academics there and with medical students, etc., that would be important. But for a group of GPs at night time, in the middle of January, in a wet night outside, they won't want to see any patient. And it's nothing personal, that's just a bit fair. But I'm going to certainly give that talk, exactly the same talk in January. And we'll see what happens then.
I just think that the other symptoms need to be emphasised as well. Joint is a huge problem, and that's your specialist area. But a lot of kids are presenting with POTS and dysautonomia, and that's very difficult to work on.
I appreciate that, and that really isn't my specialty. I was hoping that Ben would be able to come along, but he couldn't today. Ben's over.
I think it would be worthwhile if you were giving that talk to GPs, that those aspects could be covered by somebody dealing with that, just because it presents so variably. Well,
what I could do is, if I can't get somebody else to do that, I might just do a little bit more research specifically on POTS itself and go off a little bit on a tangent.
I find I have Erlasanas and dysautonomia, and I find that the dysautonomia controls my life so much more than EDS.
Well, again, you see, it's the overlap. So the dysautonomia is manifest profoundly in yourself.
Yeah.
So it's a spectrum, you see.
Sorry, I think that the majority of us, this would be now from interacting with people, would find that the dysautonomia part would probably
predominant.
Yeah.
But I mean, hypermobile is hypermobile.
Can I just ask?
Yeah.
Dysautonomia and healthy dysgenic.
Yeah.
How do you know which is which? My smoke is very sick a lot. And how would you know if it's from the POTS or if it's from
the POTS is just an illustration or an indication that there is autonomic dysfunction.
Yeah, do you know the way that affects your digestive?
Yes, yeah.
Well, how would you know which, for what to try and treat? I'm nauseous and not so, like, is it the fact that the food goes through your stomach so slowly, or is it the fact that
it can go through your stomach very quickly as well?
Or very fast?
It's just dysfunctional.
Yeah.
It's not working.
So you don't really
know. So it could either slow on one part or fast on another part.
Yeah.
And that manifests itself in you with nausea or vomiting or feeling unwell or diarrhea or constipation. And what would happen is you get all the tests done. Yeah. All the tests are normal. Astroscopy, colonoscopy, CT scan of that, an ultrasound of that, they're all normal. They're all normal. And it's normal. And you get so frustrated then.
And is it the collagen then in the tummy that causes all those problems?
I would have put with this. It probably is a combination of chemical imbalance with collagen abnormality as well. Because I don't think necessarily specifically it's just because the collagen is abnormal. Yes, would be that, but I think there's probably chemical imbalance as well going on.
Well, what do you do with that? Because, like, take my son for example. Like, he's only 7, and one of his big problems is he's got massive gastro problems, just constantly feeling sick, just nausea in general, really, and then he'll have kind of like diarrhea and things like that as well too. But I've gone to 2 different gastroenterologists, the second to get a second opinion on it, and I keep being told, oh, it's just, it's just one of those things and it's there, and I can't actually get treatment for it or anything.
I think the treatment is trial and error. I gave my triptyline.
On what, sorry?
Triptyline, amitriptyline is a drug we use for treating fibromyalgia.
Oh, right.
It regularizes the sleep cycle. It helps with chronic pain, but it also can reduce. A side effect of it can cause constipation. So if you're somebody who's got hypermobility problems in the bowel, sometimes treating them with amitriptyline reduces their level of pain and reduces the bowel motility as well. It can help. Now it's trial and error. It's trial and error. It really is. I mean, in rheumatoid, we have drugs we know we can get. And you try one and it works. That doesn't work, try the next one. That doesn't work, try the next one.
Yeah.
That doesn't work, try. And it's all there in the literature. And you understand us? Oh,
Yeah.
what am I going to do here? How am I going to treat this? No, I'm not an expert in POTS. We must get Ben to talk in POTS, okay? So he can talk about the cardiology. But I know a few of my patients have got abdominal problems. How do you treat it? And they've been to lots of gastroenterologists in Cork, and one recently in particular. Everything's fine, all the tests are wrong. Just try and learn it, so you try amitriptyline, you try Cymbalta. Cymbalta is a drug used for depression. But I use a lot of it for patients with fibromyalgia. And it's just trying to learn. Unfortunately.
Can I just ask a question, just to go back to something you said about heightened awareness of pain earlier in your talk? And one thing I'm curious about is that things like subluxing joints or going over constantly on your ankle, and I know very much through my life, I'd have a habit of getting straight up again and not feeling the pain instantly and carrying on walking or carrying on being normal. So where does the heightened awareness of pain come in? Because it would ache later on, but at the time,
well, that's just you. When we read the literature, we go through a population of patients with ALS standards. That's one of the things that they actually say. I mean, you as an individual are obviously different. Again, I think it goes back to what I was saying initially. It's all an overlap. Everybody is different.
Because sometimes I think that maybe perhaps you get used to doing that, but isn't it that causing damage, that pure fact that you're going over on your ankle all the time?
Absolutely.
Also, the pain would be a good thing at that point if you're used to it for long.
Absolutely, yeah.
I think we tolerate pain much better as well.
Yeah, perhaps that might be.
Yeah.
Well, I mean, again, going back to patients with rheumatoid who haven't had treatment, they're in pain all the time. And they get used to it. They don't know what normality is.
Yeah,
you do.
Because I find there's, like, even with my son, that with certain pain, he feels it extremely heightened. And then with certain kind of EDS pain that he has all the time, it's just there all the time, so he deals with it better than the other pain.
And rheumatoid patients are exactly the same. That is very typical in patients with chronic. And what we mean by chronic is we mean long-standing disease. They get used to their pain. They don't know what normality is like. And it's only really when you treat someone with inflammatory arthritis who've been misdiagnosed or not diagnosed for years, and you treat them properly, and they say, Christ, I haven't felt like this for years and years. And they go, oh, that's what it's like. That's what we're trying to achieve. That's what our job is.
I think sometimes with children in particular, they have a hypersensitivity to food, the same as you have hypermobility, and that I think we need to look at the whole digestive system much more than is looked at, because I think if there's one organ of your body not working, the rest of your body gets stressed out from trying to get that organ to work, and I think that's what we need to do, because I think that can be controlled, what you're talking about.
It's a pity there's not a coordinated team approach with different specialists involved, because people generally need a range of specialists in
I agree totally. I mean, if we could get rheumatology, cardiology and gastroenterology together.
I think we could rope in a psychologist as well at some stage.
A psychologist, physical therapist,
psychiatrist, sorry.
Psychiatry, multifaceted. If we could do that. We need to get people interested.
I don't know about any other one else, but I know that I can't take certain medications because my body just does not handle them. Like I've tried Lyrica, and like my stomach, like my muscles like relax too much, so then they start spasming and I'm in too much pain. And then if I take like antibiotics and stuff, I just automatically get sick. Like my stomach is just the way it's working at the moment is destroyed from the pot side of things, that literally I could eat and I just want to get sick again. You know, it's just constantly all the time. Like I'm living on anti-sickness tablets to try and eat, you know, now. So I think like that's a huge thing for me, because like it's hard to go out when you feel nauseous all the time and walk around and you know.
And it's trying to find a treatment that works.
Yeah, you know,
and a lot of it is just trial and error, because there isn't research. Certainly not in this country.
There really isn't anything.
What tends to happen in this country is you from a medicine point of view, You spend so long trying to get a consultant's post, right? You get so much, so many years of toil. And once you get the post, all they're interested in is practicing. They're not interested. A lot of them are not interested in academic. Very few people. It was different in the UK. There's such a huge population there. And I know that in particular, because I mean, if you go up to Glasgow, if they got an Ehlers Danlos society in Glasgow, or if they get an expert in Glasgow, no, it's not London. I mean, 60 million people in London. So you're going to have one person, or you're going to have one group. You will always have a group around it in a centre of excellence.
The problem for people though is cost.
Yeah.
And there's no way of getting it back because VHI won't reimburse it. None of the healthcare people will do it. And you know, if you're going through treatment abroad, it's very costly for people. You know.
Well, you must remember in the UK that people pay 9% of their income to the NHS, and that's what they're looking at here, paying 9% of the income on top of what we're paying already. And that's another whole issue altogether.
Yeah.
But you must remember over that every citizen in the UK who pays 9% of their income to the NHS. So that when you go to the NHS, then it's free, and you can choose to take out insurance if you want. Now they may want to introduce that here, and if they don't, that may be something different. I don't know. I agree with you.
And you know, you can go once and you get your diagnosis, but people can't trek back and forth for various treatment options.
The problem is the treatment options aren't there.
Yeah.
And again, it's all trial and error.
And a lot of the problems, I think, with EDS as well is because it's genetic. You've got a couple of members in the family suffering from
it's
it.
Family,
so you've got.
I unfortunately had to rush through the end because we were going over time. But I mean, you've got to embrace everybody. But that happens, and remember, it happens in other chronic diseases as well. It's not just the individual that suffers. It's the family that suffers. Fibromyalgia, for instance, moody mom, cranky, irritable. Right? Everybody gets it. But you have to embrace the family as well.
She agrees with you.
I didn't see that.
I think we'll have to move on now. But does anybody want to stand up and kind of move or anything before the next talk?